Dentigerous, also known as follicular cyst, is the most common odontogenic cyst after the radicular cyst. It is usually painless and can reach a substantial size. The reason for its formation is the accumulation of fluid between the crown of an unerupted tooth and the reduced enamel epithelium. The mandibular wisdom teeth and the maxillary canines are most often affected by the follicular cyst. They tend to grow slowly and can displace adjacent teeth. They can affect a single or multiple teeth. The literature suggests that people after their 20s are affected the most, and male to female ratio is about 2 to 1. This is the X-ray of a 10-year-old patient. We can clearly see a unilacular, well-defined radiolucent area that affects the right-hand side of the mandible. The lower right first premolar and canine are significantly displaced. The initial diagnosis was dentigerous cyst, and it was confirmed by histology. When we observe the large lesion, we should also consider odontogenic keratoid cyst or ameloblastoma as differential diagnosis. Appropriate treatment for those cysts are enucleation or marsupialization. Due to the size of the cyst and the potential risk of fracture of the lower jaw, the oral surgeon performed marsupialization, and our goal was to try to erupt the impacted teeth and bring them into the arch. By doing so, we were hoping that the bone defect would be reduced and we could improve the well-being of the child. This panoramic X-ray reveals the result of the decompression and depicts the initial healing process. The size of the cyst is reduced. The position of the lower canine has improved substantially, but now it is in a very close proximity to the root of the lateral incisor. A CBCT was performed before orthodontic treatment was initiated, and we can clearly see the radicular cyst in the upper right-hand side, which was not visible on the X-ray. A transposition of the upper right canine and first premolar could be detected as well. The different cuts from the CBCT were extremely important to me because I wanted to make sure that I will plan the tooth movements in such a manner that I will not collide the roots of the lower incisors with the impacted canine and subsequently cause a resorption of the roots. Those are the initial intraoral photos of the patient. We can see the reason for the radicular cyst in the upper jaw. That's the severely destroyed first deciduous molar. We can appreciate the severe lower midline deviation to the right and the lateral open bite on the right-hand side, which is the result of the cyst. Fixed braces were bonded, and I used lower segmented mechanics in order to upright the lower incisors and move them away from the canine. The upper deciduous molar was removed on the following day. A few months later, a new X-ray was taken after the position of the incisors was improved. The lower right second premolar was surgically exposed and a bracket was bonded. I wanted to upright and distalize it in order to create space for the impacted first premolar and canine. After the lower right 5 was brought into position, that gave a chance for the first premolar to erupt spontaneously, and the canine could be noticed as well. My goal was to create enough room in the dental arches and facilitate the spontaneous eruption of the teeth. Basically, I was just trying to keep things simple. The next panoramic X-ray shows the nice healing process of both cysts. Orthodontic mini implant, or TAD, was inserted in the upper arch and it was ligated to the lateral incisor. I used vertical elastics from the upper right too in order to erect the lower canine, and that gave me a chance not to cause a cant in the occlusal plane. We can see the improvement in the lower arch, and here I started dealing with the transposition. Very soon afterwards I realized that the tat has to be moved to another position. The next OPG shows us the cystic cavity in the upper jaw, and basically it was completely healed. We can see that the upper right canine is almost in place, and I'm opening space for the first premolar. I'm using open coil in order to do that, and now you can see that the orthodontic mini implant is moved to the left hand side of the patient. The 4 consecutive panoramic x-rays review the process so far and the healing process that took place. I think it's a good overall good progress. We can see from the frontal shots, we can see a tendency for posterior crossbite on the right hand side, and that should be addressed once the first premolar is brought into the arch. In order to do that, I would use intermaxillary elastics from the palatal side of the upper right 6 to the buccal side of the lower right 6. Those are some lateral views. There is a nice improvement on the lateral open bite on the right. The occlusal shots reveal the development of the dental arches so far. The power chain that I'm using in the upper arch will help with the derotation of the premolar, and next time I should be able to bond a bracket and bring the first premolar into its proper position into the arch. In order to achieve a predictable treatment end result, there are a couple of components that are equally important in my opinion. The first is the proper case selection and aiming for realistic treatment goals. The second is the teamwork. The people that you work with are extremely important, and their passion about the job makes a huge difference. Last but not least, things should be kept simple, and we should never try to cheat biology. Those are the basics and fundamentals in my opinion, and this is what I teach in my seminars and my courses. If you're a dentist and if you're interested in the orthodontic courses, trainings or consultations, you can check our website for more information.